Today we'll be reviewing Zofran in a bit more depth. With this PowerPoint, you should have received a link to a short Google Forms quiz. You'll receive CEs for the training after you submit the quiz. So what does Zofran do? It's an antiemetic, which means that it blocks the receptors that stimulate vomiting, leading to less puke in the back of the ambulance. How does it work? Well, first, it is a serotonin 5-HT3 receptor antagonist, which means that it blocks the effects of serotonin at a cellular level, preventing the vagal nerve and area postrema from initiating a vomiting reflex. Serotonin is a naturally occurring chemical that is critical to several human functions, from transmitting nerve impulses between cells, affecting mood and anxiety, and promoting blood clotting. However, about 90% of the serotonin in a body occurs in the GI tract and is released by the body to stimulate vomiting if certain chemicals are detected in the stomach or bloodstream. If the serotonin receptors, found mostly along the vagal nerve in the area postrema in the brain, are blocked, the vomiting reflex will be suppressed. So when do we use it? First off is for prevention of nausea and vomiting. If given before or concurrently with medications that have a side effect of nausea and vomiting, particularly narcotics, Zofran can help alleviate the potential for those symptoms. If a patient is fully immobilized, consider administering Zofran prophylactically prior to any transport or any narcotic administration. The risk of a fully immobilized patient aspirating after vomiting are much greater. Secondly, we administer Zofran to control active nausea and vomiting. With an actively ill patient, administration of Zofran can relieve the patient's symptoms. If given via tablet, instruct the patient to keep the tablet under the tongue until dissolved. Although studies have shown this route is not absorbed significantly faster than swallowing, it does ensure the patient gets the medication and does not simply vomit it back out. A third reason to administer Zofran is for motion sickness. Motion sickness has a different mechanism than chemical-induced nausea and vomiting works on. While Zofran is commonly administered with motion sickness or prophylactically for motion sickness in the EMS setting, there have been no conclusive clinical studies showing it is effective against motion sickness. However, Zofran is a safe drug to administer, and there is plenty of anecdotal evidence that Zofran can prevent vomiting with motion sickness. So what can go wrong with administering Zofran? For significant events, we have hypersensitivity, QT prolongation, and serotonin syndrome. Hypersensitivity, such as anaphylaxis and bronchospasms, is more likely in patients who have had adverse reactions to other 5-HT3 medications, such as Anzamet or Kytric. Occurrence in the general population is less than 1%. However, Zofran is contraindicated with any known hypersensitivity to these medications. QT prolongation. Administration of Zofran, particularly in large doses, can cause EKG changes, most commonly a prolonged QT interval. While this is usually a benign characteristic, in patients with pre-existing cardiac conditions, this can cause potentially fatal arrhythmias to occur. Clinical studies have indicated that doses under 16 milligrams are very unlikely to have any effect on the QT interval. Occurrence again is less than 1%. Thirdly, we have serotonin syndrome. Serotonin syndrome is a condition that occurs with certain medication use and inadvertent medication interactions. Zofran alone can cause serotonin syndrome. However, it is more commonly seen as a side effect when Zofran is used with other drugs. The only other high-risk drug that Yosemite EMS uses is fentanyl. Patients can present with a range of symptoms, which can be lethal. A triad of symptoms is usually seen, including mental status changes, such as agitation, delirium, and coma, neuromuscular changes, such as rigidity, incoordination, and tremors, and gastrointestinal symptoms, such as nausea, vomiting, and diarrhea. If these symptoms occur, discontinue use and provide supportive treatment to the patient. Occurrence again is less than 1%. So what else can go wrong? For less significant events, we have headaches with an occurrence of 9 to 27%, constipation, 6 to 11%, though generally only seen with prolonged use, and hypoxia, occurrence 9%. Zofran is a Class B pregnancy risk drug, which means there is no evidence of risk to the fetus. While Zofran is often prescribed for morning sickness, clinical studies have shown that it is not the most effective drug for it. However, in an emergent setting, Zofran is the appropriate choice for nausea and vomiting, regardless of the cause. Some considerations for administering IV, IO, and IM. Zofran is provided in a 4 milligram per 2 milliliter vial. Each ambulance medkit has 4 vials available. Some side effects are seen at higher occurrence rates with IV, IO, and IM administration. When administering IV, IO, deliver with a slow IV push over 2 to 5 minutes. Increased side effects are seen at much higher occurrences with a faster administration. Here we have the drug formulary for Zofran. This appears in your protocol book as well, but I'll give you a few seconds here to look over it. So for puking kids, Zofran is considered safe for pediatrics with limited, not extended duration use. For children 4 to 14 years old, IV, IO, and oral doses are all the same as adults. IM dose is 0.2 milligrams per kilogram to a max dose of 8 milligrams. For children under 4 years old, call medical control for administration. Do not administer Zofran to children under 4 in communications failure. So far in 2017, there have been 97 calls in which Zofran was administered. 21 of those calls, Zofran was administered in an ODT tablet. And we have one lonely BLS provider who used their full scope of practice and administered Zofran ODT during their call. A significant portion of these were administered for motion sickness, either prophylactically or in response to symptoms. While this is a valid treatment option and well within protocol, remember that Zofran is not always effective against motion sickness, and don't be surprised if the medication isn't effective. We're now going to run through a scenario taken from a well-run call earlier this summer. Some details have been changed or added to better fit into a neatly packaged scenario. You may want to open the associated Google form quiz. The questions posed during the scenario are part of the short quiz. You can save a little bit of time by typing them out as we go. The quiz does need to be submitted for CE credit for this training. So in your scenario, you are dispatched to the top of Nevada Falls, 3.5 miles from the trailhead, on a warm summer day at approximately 5 p.m. You're dispatched for a 19-year-old female with a heat-related illness, and upon your arrival, you find her lying in the shade, alert and orientated ×4, and behaving normally. Her airway is patent. She's breathing normally on room air. She has no signs of bleeding, and her pulse is strong and regular. Her skin is pink, warm, and dry. At this point, her chief complaint is nausea with earlier episodes of dry heaving. So at this point, what specific assessment points are you looking for to make a differential diagnosis? And what specific questions would you ask the patient? The patient denies any current medications or allergies. She states she experienced heat exhaustion 6 years prior with a similar presentation. She says she drank approximately 2 liters of water, 1 liter of Gatorade, normal breakfast and lunch, and has eaten snacks throughout the day. Her vitals are blood pressure 112/64, pulse of 108, respirations 18, SpO2 95% on room air. Her skin has moderate tinting. So at this point, remember that you're a single provider, several miles from the trailhead. What are your treatment options and what are your transport options? For this call that we based the scenario on, 4 milligrams of Zofran was administered, ODT. Afterwards, oral fluid rehydration was initiated. After 15 minutes on scene, medical control was consulted. After 30 minutes after initial treatment, patient stated she felt able to walk. Patient stood and walked around the area and stated she was not experiencing any nausea, dizziness, or weakness. 45 minutes after initial treatment, patient and providers began walking down the trail. Vitals were taken at regular intervals, and patient continued to report improvement. After about 1 hour heading down the trail, the group arrived at the trailhead and patient AMA'd. For the final question, would you have any concerns with an AMA after administration of medications? Again, make sure that you complete and submit the Google Forms quiz in order to receive CEs for this training. And thanks for following along.